Okay, so we're going to go over antihypertensive agents. The learning objectives on this is going to be we're going to go over the mechanism of hypertension, and then we're going to touch on the different antihypertensive agents. I'm going to go over a little bit with the JNC guidelines. And we're going to go over like an overview of the antihypertensive because in the upcoming weeks, we're going to have on the 30th, when I see you in person, we're going to be going over the adrenergic inhibitors, the vasodilators, the ACE inhibitors, and the ARBs. And then a couple weeks after that, we're going to go over nitrates. We're going to go over diuretics. So I'm just going to go over, in general, the mechanisms you need to know for antihypertensive to get a good introduction. So hypertension is defined as an elevated systolic pressure, diastolic blood pressure, or both. The Joint National Committee for Prevention, Detection, Evaluation, and Treatment of High Blood Pressure, also known as the JNC. We are up to the JNC 11. So it officially defines hypertension as a diastolic blood pressure reading of over 90 millimeters of mercury or a consistent resting systolic blood pressure above 140 millimeters of mercury. If you're over 60, though, the definition will be 150 systolic over 90. There's three types of hypertension. We have primary or essential hypertension. This is the term that we use when the cause is unknown. And generally, the patient doesn't have any symptoms. This type accounts for about 90% of known cases of hypertension. Malignant is a moderate or severe situation, and that can lead to heart, brain, or kidney damage and can be fatal. So, malignant hypertension is serious. And we always talk about TOD, target organ damage. So, when someone runs around with chronic high blood pressure, we do know that we get vascular changes in the brain. We get them in the heart, in the coronary arteries. Also, remember on the vessels, if we have that chronic hypertension in the vessels, you have increased systemic vascular resistance. It's going to put strain on the left ventricle and can lead to a left ventricular hypertrophy. So we do know that is going to actually be a big strain on the heart. We do know that when you have malignant hypertension or any hypertension long term that's not managed, we know that that high systemic vascular resistance will be elevated. It will affect cardiac output, and those high resistance is damaging the kidney. So we can get changes in the kidneys over time, and that can lead to eventual kidney dysfunction. So we do know that also, just like diabetes, when we talked about that target organ damage, we get this with long-term hypertension too. Secondary hypertension refers to a hypertension that could be known from something else, another disease. So pregnancy, we do know blood volume increases during pregnancy, and we will see in some instances they develop what's called PIH or pregnancy-induced hypertension. I think there's also it can go into preeclampsia. Preeclampsia is a high risk of preterm birth. Because of the hypertension, you're going to have issues with the vessels, the fetal circulation. So preeclampsia is when you have hypertension in pregnancy that's affecting the baby, and they will check the urine frequently in moms to see if they're dumping proteins. If they're dumping proteins, that means that the high pressure is affecting the kidney. If it's affecting the kidney, it's going to be affecting the fetus. The other thing that you want to think about is eclampsia. Eclampsia is when they are at risk for seizures, and these patients will be hospitalized or on strict bed rest, and they will be monitoring to make sure they don't go into preterm labor. Kidney disease. So we do know, I'm going to go into the renin-angiotensin-aldosterone system with you, but we do know that kidney disease can cause an underlying hypertension, and then tumors of the adrenal glands. If you remember, a pheochromocytoma can form in the adrenal medulla. And that can cause this high levels of epinephrine and norepinephrine to be secreted, and that can cause tachycardia, hypertension, things like that. Usually, if you do if you remove that tumor, usually the blood pressure will go back to normal quickly. The other thing that we need to think about is the adrenal cortex. Remember, salt, sex, stress. And the cortex has aldosterone, which is responsible for reabsorption of sodium. So obviously, any kind of tumor that is going to be in the adrenal cortex that may cause the cortex of the adrenal gland to secrete excessive aldosterone is going to lead to increased reabsorption of sodium, which can obviously increase blood pressure. Also, diabetes, we know that that can cause some endothelial damage on the vessels, and that could cause them to get rigid over time, and that could also lead to increased systemic vascular resistance, leading to hypertension. So they're the three types of hypertension. What are the risks that we see that are associated? No discussion is complete without addressing factors in lifestyle that can contribute to the development of hypertension. And some are controlled, some are modifiable, and some are not. So it's really important that you understand the major controllable or modifiable risk factors for hypertension, the things we can change. Smoking, we can quit smoking. We know nicotine causes vasoconstriction, and vasoconstriction increases peripheral vascular resistance. We also know nicotine is very damaging to the endothelium. And then obesity. There's a lot of studies on central obesity. So that means the central obesity is what do we call it? Our 12 pack or whatever. It turns into a beer belly. It's usually the fat that's around the organs. Okay. So we call that central obesity. Oral contraceptives and some over-the-counter medications. We do know that non-steroidal anti-inflammatories like ibuprofen, Advil can cause blood pressure to go up. We do know oral contraceptives have an impact on cholesterol and also on hypertension. We do know that high blood cholesterol or lipids also can contribute to hypertension. So diet modifications only, but not genetic. So remember, there's high cholesterol. We called that familial. You can have homozygous or heterozygous familial hypercholesterolemia. Those we cannot modify. But the dietary cholesterol we can. So the unmodifiable risk factors, okay? So these are the ones we cannot change. We have diabetes. We have diabetes type 1. We can't really change that. We don't make the insulin anymore. Genetics, family history of heart disease in females, usually under 65, and males under 55. So if we see a family history of heart disease, we do know that genetics play a factor. As you know, you cannot change who you're related to. African Americans do have the highest incidence of hypertension at younger ages than their Caucasian counterparts. We do know over age, over 60, as we get over 60 years old, we do see some isolated systolic hypertension, but they don't have any signs of organ damage or the absence of other symptoms. It is a major risk factor, though, for stroke, left ventricular failure, and death. So we will give that leeway, like I said in the beginning, for patients over 60 years old. Typically, what we can do with those is give them a little leeway. So we might have them at like a 150 systolic rather than being so strict with the 140, because over time it's normal to develop some calcifications on vessels. We do know when we do carotid vascular studies, we do see in patients that are over 60, they do have age-related vascular changes. Gender. I know, genetically we can't really change that, and hormonally, right? So I know we can touch on transgender issues. Genetics plays a role in because of hormonal changes. So if you have a transgender that is now taking testosterone, so you may have a female transition to a male and now they're on testosterone. They may have a higher risk factor even though they were genetically female. So I want you to always remember estrogen is cardioprotective. Once they go through menopause, then we have higher risks of heart disease and hypertension. So, just keep in mind gender risk factors can be either genetic or hormonal. And that's why transgender populations, we have to look at that whole picture. Race, African American populations are at the higher risks for hypertension and stroke and heart disease at younger ages. So, what are the risks that I always talk about with target organ damage? This is with patients, not your patient that comes in, they're borderline, we manage them, they do lifestyle modifications, and then they go ahead and they go on a medication, and we're finding them to be relatively controlled. These are the patients that are uncontrolled. So, if hypertension is uncontrolled, damage will occur to target organs. So, this is your TOD, target organ damage. The damage may appear as a stroke. We have high systemic vascular resistance. We knock a plaque off. It goes into the brain. Now we have a CVA or a stroke. Aneurysms. Remember, we have the weakening of vessels in like the aorta, even in the brain, and it can hypertension or systemic vascular resistance that's high can cause weakening of vessel walls, and that can lead to an aneurysm. Transischemic attacks. I heard little rumblings. They're trying to get rid of this term because what it is like something happens that causes a little neurological change, whether a little clot goes through or a little plaque, and they get a temporary weakness or change, or they have maybe some paralysis, and then it goes away very quickly. Those need to be taken very seriously, and this is a risk associated with uncontrolled hypertension. And we do know that if patients have a TIA, they do have a 60-80% chance of having a severe cardiovascular event or stroke within a year. Kidney disease, we do know that the kidneys can be damaged, retinopathies at the back of the eye. So when we know somebody has hypertension, they'll see their eye doctor more frequently, and they'll actually take a look at the retina. And we do know that retinal tears can happen. We do start to see what we call AV nicking. It's called arterial venous nicking. So if you have these high pressures, those little fragile vessels in the back will actually you can see changes on those vessels. Okay. In diabetics, we tend to see these cotton wool patches. So we do know that chronic uncontrolled hypertension can lead to blindness because of the retinopathy. Peripheral vascular disease, we do know with hypertension, if you get enough damage, you can end up with arterial vascular disease. We call that peripheral vascular disease, PVDs. Fall under, that's a category where you'll have arterial insufficiency. What that is there's so many plaques all built up on those arteries in those legs that they end up not getting enough oxygenated blood circulation. So you may see loss of hair. The extremity might be really cold. The toes look very bluish or pale. And then on the reverse is vascular disease affecting the venous system, where you'll see venous stasis or chronic venous insufficiency, where we can't get the blood back up to the heart. So the extremity gets really warm and red and sometimes wet because that blood is causing high hydrostatic pressures, kind of squishing, and they'll get like swelling and it'll be very hot. So we do see peripheral vascular diseases that is a risk associated with uncontrolled hypertension. Various cardiovascular problems, which create an increased workload on the heart and increased myocardial oxygen consumption. We're talking about angina. We're talking about chest pain, congestive heart failure. Okay, so if it can't get the blood out, what's going to happen is it backs up. And that's how we're going to end up with a CHF, or a congestive heart failure. And we are going to go over drugs that we use for heart failure later. So I will get into more about heart failure again. But remember, the more resistance the left ventricle has to go against in diastole, um, we want a low number in diastole, because that's when we're in diastole and the left ventricular is relaxing, the aortic valve is closed, and that's when those coronary arteries are perfusing. So we're going to have an issue with angina or chest pain. If the left ventricle gets involved with the hypertrophy, that will cause a backflow into the lungs, and they'll get short of breath. If it moves to the right, then we're going to see some problems with uh, uh, cardiac output and CHF. We do know myocardial infarction. This is a risk factor for a heart attack, is uncontrolled hypertension. So what do we do? So they stratify the risk factors. They put patients into categories. I do not have a separate handout for that because it's constantly changing. So what I'm going to tell you for now, the most updated thing is that according to the blood pressure values, we were categorized them as to are they in good control? Are they pre-hypertension? Are they hypertensive? Are they malignant hypertensive? So we want them under 140, under 90. We'll see. Does JNC come out with another one? We'll see with another recommendation. But right now, that is the recommendation. So in all stages, what we are going to do is definitely we're going to consider lifestyle changes first. So that would be low sodium diet, low cholesterol diet, regular exercise. We're going to tell them to do 150 minutes a week of exercise, and also weight loss. So we usually shows that 5-pound reduction in body weight significantly reduces blood pressure, and in turn can reduce the risk of stroke. So we do, when they come in, we do typically will get that high blood pressure read, unless it's not horrible, okay? But we'll say, you're having early hypertension, or you're hypertensive, and we're going to recommend that we, have you do some lifestyle changes. You want to teach them how to monitor their blood pressure at home. That's really important. So they need to get a good blood pressure machine. We like the Omrons, OMRON. They seem to be pretty reliable. They're cuff. So we have to be able to teach our patients how to properly use that cuff, and have them check their blood pressure either once a day when they're not, like, relaxed, not like all stressed out, or maybe even twice a day, like the morning and in the evening. It would be important to educate them that you need time. Okay. It's not, you're not going to do a change in a week and see that, but we need to give them time to make those changes. Once we make those changes, then we can consider, after 3 months of trying to get the blood pressure down, let's see, maybe we might have to initiate medications. But always the first thing we're going to do is we're going to do lifestyle changes. Blood pressure is controlled by a complex interaction between the nervous, hormonal, and renal systems. There's two primary mechanisms for blood pressure control. Each plays a significant role in regulating arterial pressure. So we have the adrenergic nervous system, or the baroreceptor reflex. This is a rapid action. So what it'll do, if we're in fight or flight, remember, we get a fight or flight response. The adrenal medulla will secrete epi and norepi that will bind to our alpha receptors. It will bind to our beta receptors. The alpha ones cause vasoconstriction. So just so you know, our beta 1 is in the heart, will stimulate the heart to increase contractility and heart rate. Beta 2s will cause bronchodilation, and the alpha 1s will actually get a vasoconstriction in stress. So unfortunately, when that constricts the blood vessels, like especially in the carotids, we have them, we have baroreceptors. If it picks up high stress or high pressure, it will try to do things to decrease that blood pressure. The renin-angiotensin-aldosterone system, I'm going to pull that up. So you know that I love this system. The renin-angiotensin system is basically when we have low blood volume, we are picking up low blood volume, that's low blood pressure. Or, you know, the kidneys will detect that because that's detecting cardiac output. So it doesn't know if we are hemorrhaging to death. It doesn't know if we're vasodilated. But what happens is the kidneys will pick up on that. They will secrete renin. The renin will trigger the liver to make angiotensinogen. That will convert when renin's present into angiotensin 1. And then remember, this is secreted by the liver, the renin secreted by the kidney. The angiotensin 1 is inactive. We need angiotensin converting enzyme, which will be found in the capillary walls, or it's even found in the lungs. And then that angiotensin converting enzyme will convert angiotensin 1 to angiotensin 2, will trigger the adrenal cortex, remember salt, sex, stress, to release the salt component, which is known as aldosterone. Aldosterone is the most potent mineral corticoid that we have, and it will increase the sodium retention in the kidney. And that will increase the retention. And we all know where salt goes, water will follow. So when you look at this, you know we're going to talk about drugs coming up, right? We're going to talk about that next week. We're going to talk about angiotensin converting enzyme inhibitors. We're going to talk about adrenergic inhibitors, beta blockers, things like that. We're going to talk about angiotensin receptor blocker. So we're going to actually have an effect on right here. I'm sorry, in 2. So we'll be able to block 2, and that will also stop this cycle. So if you think about it, there's a lot of components that will kick in. I also want you to remember that once renin kicks in, the sympathetic nervous system also gets activated. So that will even do more effect like vasoconstriction. Okay, so you have a good handle on that. This is a longer acting system where your sympathetic nervous system is quick. So in here we have the adrenergics. The adrenergics are the sympathetic, uses a reflex with the baroreceptor reflex. It's rapid control. We need this or we would pass out, right? But it gets activated when short-term control and it can detect high or low pressures is needed. So there's specialized nerve endings located along the inside walls of the internal carotid arteries and also in the aortic arch. And these receptors will respond very quickly to changes in pressure. So when pressure within the arterial lumen becomes suddenly elevated, then the baroreceptors get stretched and they interpret that stretch as an elevated in pressure. And then that stretching will transmit an impulse to the vasomotor section of the brain. And once that's stimulated, the vasomotor center responds by causing 2 things. We could get a decrease in the heart rate, or we could get a decrease in the force of myocardial contractility. These actions will lower the cardiac output. This is the body's attempt to say, I'm going to lower the blood pressure. We will also see this reflex causing vasodilation. So the vasodilation of the peripheral vessels, which decreases the peripheral resistance. And again, the goal is to reduce blood pressure. Okay? So blood pressure is attributed to also the baroreceptor reflex arc. Over long periods of hypertension, though, this is the danger. Those baroreceptors actually become more permanently stretched, and then eventually they're less responsive to sudden blood pressure elevations. So what's research has shown is that the baroreceptors kind of reset and they allow higher levels of blood pressure. Hence also what happens as we age. Okay, so these are age-related changes, but in this is a pathologic, right? So in chronic hypertension, this is what can happen. They get permanently stretched. When blood pressure is suddenly low, this information also gets transmitted to the vasomotor center of the brain, and that will say, whoa, you sympathetic nervous system, kick in. This is the autonomic nervous system branch of the sympathetic, right? And the sympathetic system tells the adrenal medulla, let's make some epi and norepi. And then if you recall, the norepi will hit the alpha adrenergic receptors that are in the vessels. It has an affinity for the alpha adrenergic receptors to cause that vasoconstriction. So the alpha 1 receptors cause vasoconstriction. That's why we do use alpha blockers. Okay, we can use alpha blockers. You won't see them used a lot because unfortunately they cause vasodilation. That could make people prone to getting up and getting orthostatic and maybe passing out. The other thing that can happen is it works on the urinary sphincters and it relaxes them a little. So you will see the alpha 1 receptor blockers used in patients that have hypertension with enlarged prostates that have an effect on the urinary system. So we don't use alpha blockers routinely and they're not first line. Okay. Um, all in addition, the beta adrenergic receptors, remember your beta 1s, that's going to cause, if I stimulate them with norepi, it's going to increase the heart rate, and then you'll get an increase in the strength and the force of contraction. And then this activity results in an increase in blood pressure. Epinephrine acts on both the alpha and the beta receptors also. It produces a vasodilation in skeletal muscle without increasing peripheral resistance. However, epinephrine does produce a marked increase in heart rate and contractile force. So it will increase cardiac output. And then in that relation, it will increase blood pressure. So we have renin-angiotensin-aldosterone system that I went into, and that regulates the blood pressure by increasing and decreasing blood volume through the regulation of kidney function. I want you to also remember there is a result on antidiuretic hormone, which is situated in the posterior pituitary. Okay, so just remember when the renin-angiotensin-aldosterone system gets activated, typically the sympathetic branch will get activated, and then also you will get signals to the brain, to the hypothalamus, which will send it down to the posterior pituitary, and it will signal to release antidiuretic hormone. And when that happens, we will get retention of fluid. So we'll hold on, we'll have less urinary output because if you increase blood volume, you will increase blood pressure. Okay. So we do remember low cardiac output or any hypoperfusion state. I don't care if you're hemorrhaging, you're in severe heart failure, you had an MI, you have low cardiac output. This will cause that renal arterial pressure to notice that it's reduced, and it will trigger the kidney to go ahead and secrete renin. The other thing that can do that, not just low cardiac output, but in some patients, they develop a renal artery stenosis. So just like you get coronary artery stenosis, you could get it in the renal arteries. And if that happens, the kidney is going to detect low perfusion. So they may have this high blood pressure with a renal artery stenosis. But the kidney doesn't know that. The kidney knows I'm not getting enough fluid because there's all this stenosis in the renal artery that's bringing blood flow from the aorta and the heart into the kidney. And when you get that, the kidney's like, I'm not getting enough. And it triggers that renin-angiotensin-aldosterone system. It's crazy. So I had some patients, they were nuns, and they would come in, and no matter what we did, we could not get this blood pressure down. So they did carotid studies, they did an echo, and then they decided to do abdominal ultrasounds. And it turned out that a couple of our little nuns had some renal artery stenosis, and that was what was doing it. So they just went in, they put in renal artery stents, and that helped. Okay. So we have to think about the things, not just, low blood pressure or low blood flow, but think about cardiac output and the flow of blood reaching the kidney that will trigger this renin-angiotensin-aldosterone system to trigger renin. Renin is the enzyme that catalyzes the reaction that produces angiotensin 1. Angiotensin 1 is a weak vasoconstrictor, and in small vessels of the lung, angiotensin 1 will get converted to angiotensin 2 with the help of angiotensin converting enzyme. So angiotensin 2 does two things. It vasoconstricts the arterioles, it increases the vascular resistance to increase blood pressure, but it also will tell the adrenal cortex to secrete aldosterone. And we do recall that aldosterone is the hormone that causes the reabsorption of sodium by the kidney. And that increase in the serum sodium changes the osmotic pressure within the plasma. And then it stimulates the release of antidiuretic hormone from the posterior pituitary gland. Angiotensin 2 also promotes reabsorption of water from the proximal tubules in the kidney. It takes time. So the renin-angiotensin system takes a longer period of time. The sympathetic is a little quicker. We're going to talk about in upcoming weeks, we are going to talk about adrenergic inhibitors. We're going to talk about beta blockers, centrally acting ones, peripherally acting ones. These are things that we can use if someone comes in and we have to either start a beta blocker or start a drug that will help lower the adrenergic response, or we have to act fast. Okay, and we are going to talk about that next week. We did cover beta blockers, but we're going to cover them again because they're not technically on the JNC guideline as a first line pharmacological therapy, but we do see some patients it works for and they've been on it for years and they stay on it because it was on the old guidelines, not anymore. The first line that you're used is diuretics. So we're going to go right to hydrochlorothiazide or chlorothalidone. I'm going to be covering that in later weeks about diuretics because we're going to cover heart failure. Also, we want to talk about ACE inhibitors. We're going to talk about them next week. ACE inhibitors prevent the conversion of angiotensin 1 to angiotensin 2. Then we're going to talk about angiotensin 2 receptor antagonists. They're the ones that block angiotensin 2. So we're going to, ACE inhibitors end in pril. Adrenergic inhibitors like beta blockers end in pril, in a lull. And then our angiotensin 2 receptor blockers, we call them ARBs, or now they're moving to even calling them aldosterone inhibitors. They are called ARBs, okay, and they end in artin. So we have adrenergics for beta blocker is going to be alol, OL. ACE inhibitors end in pril, and our ARBs end in artin. We're also calcium channel blockers are on there. So the four main components of pharmacotherapy, remember, first line is lifestyle changes, okay? But then the second line, if that doesn't work, we're going to move into diuretics first. If they're African American descent, then what we have to do is we're going to initiate polytherapy. They do not respond well to just throwing an ACE inhibitor on or an aldosterone inhibitor or an ARB. They require diuretic. They don't do well. You can give them ACE inhibitors. You're going to, actually, we're going to give them ACE inhibitors and ARBs if they have renal disease and diabetes with it. But the first line for them is usually going to be diuretics. They respond well to that, and also calcium channel blockers. And you remember the the ones that end in peen are the ones we're going to use for that. Not like cardizem or diltiazem. We're going to use like amlodipine. There's the drugs that are the calcium antagonists or the calcium channel blockers we're going to move to. African Americans do very well with calcium channel blockers and diuretics. And we do have to initiate ACEs and ARBs. You never put a patient on an ACE inhibitor and an ARB. Okay, but you can put them on a diuretic and an ACE or a diuretic and an ARB, but you can't do an ACE inhibitor and an ARB together. Also, they do retain potassium. So we will get into these details later. We're also going to, in another week, going to talk about vasodilators. We do use them sometimes like hydralazine or nitro to get a blood pressure down, but they are not in the JNC guidelines. The JNC guidelines are diuretics, ACEs, ARBs, calcium channel blockers. Choice is going to always be dependent upon the demographics. So African Americans tend to respond better with diuretics and calcium channel blockers than the ACE inhibitors. And they may respond better to ARBs. And they also, age affects blood pressure, and so does the length of time a woman has been on oral contraceptives. So we do have to consider a lot of these things. Also, coexisting disease states. So beta blockers and calcium channel blockers might be well for patients that have chest pain or atrial fibrillation or tachycardia. In type 2s, acute adult onset of diabetes, the diuretics seem to do worse. Do better, I'm sorry. And new evidence is showing now that diabetics benefit from our ACEs and should be prescribed even small doses. So in patients with asthma, beta blockers we tend to avoid, remember, because some of them are non-selective. Pregnancy, hypertension in pregnancy is very serious. And I mentioned this earlier, but preeclampsia is the primary factor in fetal and maternal morbidity and mortality. Remember, mortality is death, morbidity is illness. And some hypertension can actually start before the 20th week of pregnancy. And if they're diagnosed early, diuretics that are mild or like methyl dopa can be used for control, but ACE inhibitors and ARBs are absolutely contraindicated and are not recommended because the fetus can't handle them. Sexual dysfunction, this is a common complication of chronic hypertension, but also it tends to also be a side effect of some antihypertensive drugs, particularly like beta blockers. Problems such as decreased libido, impotence, and other symptoms sometimes lead to poor compliance on the part of the patient. So we might need to just think about, what are we going to do? Maybe we can change the dose. Maybe we can do a different combination. But you got to remember, it's like a hit or miss, and it's a trial by error. So not all antihypertensive affect people the same way. We have to make it very individualized. What about patients having surgery? So, in an attempt to prevent rebound hypertension that can occur after anesthesia, it's important to continue antihypertensives up to the day of surgery and then resume them as soon as possible after surgery. So, we do want them to be in well controlled during surgery. We are going to go into all of these in the upcoming weeks, but I just want to tell you, diuretics will promote formation and excretion of urine. That will also cause a loss of sodium and water from our system. Also, through the function of the renal system, it serves to decrease vascular wall reactivity. Diuretics will decrease peripheral vascular resistance, and then they will initially decrease cardiac output. So this will cause a lower blood pressure. We do worry about diuretics causing loss of potassium and sodium. So we do have potassium sparing diuretics also, which we call aldosterone inhibitors. Adrenergic inhibiting agents, this is going to be the class of drugs that inhibits the activity of the sympathetic nervous system and reduces blood pressure. So sympathetic stimulation increases heart rate, contractility, and resistance. So if we can, and it's also the activity is responsible for the release of renin. So how can we modify that? We can use beta blockers. Okay. Beta blockers initially inhibit the release of renin. Um, and they compete for the receptor sites for the epinephrine. They will inhibit the natural response to beta stimulation. And they are recommended for those. We do use them specifically for patients that have coronary artery disease, patients that have atrial fibrillation, patients that have aortic aneurysms, but is not the first line for blood pressure anymore. Okay. But if they have underlying AFib, that beta blocker may help the blood pressure as well. Centrally acting adrenergics, they're represented by clonidine, Aldomet, Again, they are not first line. We just use them, but Altamet is a good one that we use in pregnancy, but you can't use it with patients that have depression. Um, Newer and better formulas have come on, so we're not really using them a lot. Peripheral adrenergics, these were older drugs. They lower peripheral vascular resistance, heart rate, and blood pressure. Again, there's better stuff out there. We rarely use them. Now, alpha adrenergic blocking agents, these are the ones that I told you for the alpha 1 receptors that cause vasoconstriction. They're going to block that. So you're going to get relaxation of your peripheral vessels. There's drugs we use because we only use these when a patient has hypertrophy or benign prostatic hypertrophy, enlargement of the prostate gland. Um, because they can get orthostatic hypotension. Okay, so we're not using these first line, but if the patient has hypertension and has BPH, we can put them on prozacin, doxazosin, terazosin. They end at osin. These are the drugs. So the side effects are usually going to outweigh the benefits of the other drugs, but it does help with BPH. But if they have a history of syncope, it's contraindicated. It's also good for Raynaud's because it causes a little dilation of the peripheral vessels. In Raynaud's syndrome, that's where you get exposed to cold and the vessels constrict. Also, pheochromocytoma. If we have a patient that has a pheo, remember fake chromaffin cell tumor, that's in the adrenal medulla. I love this. It's so pretty under a microscope. It's colorful. But this is the one that will stimulate the release, and you'll have all this adrenaline, and norepi, and epi running around. And that helps. This will help with that also because it will directly affect the vessels. But just remember, we're not using alphas first. Okay, so alpha 1, it constricts smooth muscle and peripheral vessels. And it also will work on the smooth muscle and the prostate. And you'll get vasoconstriction. So if we block that, you'll have that nice dilation. Alpha 2s are more on the peripheral nerve endings, and they inhibit norepinephrine release. We're going to talk about ACE, angiotensin converting enzyme inhibitors. I'm going to get more specific with that when we talk about them, how they work, and what you need to know about them. But they're like, these drugs came out, like, I would say in the 90s, and they really changed the game for patients. They really, really, it was amazing. And they helped to convert not only control blood pressure, but they actually were helpful on the kidneys. We use them for hypertension that have patients that have organ damage, that have coexisting disease like LVH and diabetes. It's highly recommended if beta blockers and diuretics are not using. These are combined with diuretics though. And we also know that if they're taking NSAIDs, they should not be taking ACE inhibitors with NSAIDs like Advil. They retain potassium. That's the one thing I want you to be aware of. And we're going to get more into this um, in the upcoming weeks, but I just want to give you a little touch. Then ARBs are the angiotensin 2 receptor blockers. They're similar to the ACE inhibitors, but they work beyond it. There's a common side effect that happens with ACE inhibitors, and if that side effect becomes too problematic, then they can move to using an ARB, very similar to the ACE inhibitors. Calcium channel blockers, we did talk about this before. We did know that they're great because they help angina. They help patients that have high blood pressure, and they're also used as antiarrhythmics. So the ones that we will use for blood pressure typically are going to be like nifedipine or amlodipine. These are going to be the ones that end in INE, very effective in patients with that are African American. We'll also talk about later weeks, vasodilators. We'll talk about nitro, hydralazine. So when we talk about Hydralazine, it's usually given IV, but it can be given PO. And then we're going to talk a little bit about labetalol. Labetalol is an IV formula, and that is, we can use labetalol in pregnancy and usually for hypertensive emergencies. So we don't use vasodilators as a first line, okay? It's just the goal for them is for immediate but modest reduction in blood pressure. And they work by reducing the peripheral vascular resistance. There's a profound vasodilation in the case for nitride. So you'll get maybe a reflex tachycardia with it. Again, labetalol is really good for hypertensive emergencies. In eclampsia, we can use it in pregnancy. And then hydralazine, we can give, but sometimes it gives them a little bit of hyperglycemia, so we have to be careful with diabetics. Okay, so this is what I have for you for today. We're going to go over more detail of the individual meds in the upcoming weeks, but this is going to give you a nice overview. I will, when I see you also, we'll go over the JNC 11. That's just the recommendations that say which drugs we should use first for first line based on medical history and race. Okay? That's it for today. And so, just make sure that you took good notes during this. If you have any questions, save it for when I see you in lecture and we will go over it. But we're going to go over the different classes next week very much in depth. Okay, that's it. Thanks.